So the next series of questions actually helps us to dive more into the anatomy of Horner syndrome. Basically, we are going to be looking at the anatomy and going to appreciate how basic knowledge of anatomy would help us to localize symptoms. Um, so, next question. You are consulted on a 76-year-old man who is referred for right eyelid ptosis and right pupillary constriction. He also mentions that when he exerts himself, he notices that the right side of his face does not seem to sweat like that of his left side. Using this information, which of the following would not be a probable cause for these symptoms? So options A says a tumor affecting C8 to T2 spinal level. Options B says a lesion between hypothalamus and spinal center of bulge. Option C says a tumor in the right lung apex. Options D says a large hematoma formation under the subclavian artery following attempted central line placement. And options E says ICA dissection following involving the mid cervical region above the bifurcation. Now, this question may look complicated, but it's actually very simple. In fact, looking at this question right now, based on our previous discussion in the previous episode, we can basically pick an answer even without knowing what a huge majority of these options is. Now, remember that we said that the sweat fibers run alongside with the external carotid artery, and that the only reason why you are going to have anhidrosis is if those sweat fibers are disrupted. That is, if the dissection occurs at the level of the bifurcation affecting the external carotid artery. Yeah. But if you have a lesion or a dissection that affects just the ICA, that will not touch the sweat fibers which are located close to alongside the external carotid artery, and that will spare them. So that means that these are patients here who has symptoms that are looking like Horner syndrome, right eye ptosis, filary constriction, and hydrosis. Most likely his lesion is located at that bifurcation, right? So um, options E is not a probable cause for this symptom. But before we go to the next question, let us take a gross look at the anatomy of I call it the anatomy of Horner syndrome. So we are going to talk about the anatomy of Horner syndrome, and by the anatomy of Horner syndrome, I mean the sympathetic pathway of the of to the eye, which is actually a three neuronal pathway. We have the first order neuron, the second order neuron, and the third order neuron. The first order neuron actually starts from the posterior hypothalamus and it moves down through the brainstem and then into the lower cervical spine and the upper thoracic spine, usually between the levels of C8 to T2. Now, this part of the spine, that this spinal segment, is actually what we call the spinal center of bulge, and this center was actually named by a physiologist, and the name of that physiologist was Julius Ludwig Bulge. Now, the second order neuron originates from this bulge, this spinal center of bulge, and we call it the preganglionic neurons. Now, when they exit the spinal cord, they travel and then they go near the apex of the lung, and after that, they just climb right under the subclavian artery and ascend to the neck. Now, ascending to the neck, they make a synapse at a place called the superior cervical ganglion near the bifurcation of the common carotid artery, which is just at the level of the angle of the mandible. Now, this makes the second order neuron. Now, we have the third order neuron, which is the postganglionic neuron, and this postganglionic neuron actually travels with the carotid artery. Now, remember we said there's a bifurcation of the common carotid into the external carotid and internal carotid. Now, that third order neuron actually follows two parts. One part follows the ECA, the external carotid artery, while another part follows the ICA, the internal carotid artery. Now, the one that follows the ECA is actually the sweat fibers and the vasomotor fibers. So they follow this ECA after branching from the superior cervical ganglion, and they travel to the face. Now, the ICA from the takes the oculosympathetic fibers, and the oculosympathetic fibers actually continue with the ICA. From the ICA, it moves into the caverous sinus and then into the orbit, and then they actually travel with the ophthalmic division of the trigeminal nerve, that is V1, to their destination. Yeah, so now that we've done that, let's go back to the question. The first option says it's tumor affecting C8 to T2 spinal levels. So we know that's the spinal center of bulge, which you just talked about, and a tumor affecting that will most likely cause a downstream effect and then cause the entire spectrum of Horner syndrome. So that's correct. A lesion between the hypothalamus and the spinal center of bulge. We know that there is usually the first order neuron starts from the posterior hypothalamus, goes down to the brainstem, and then synapses at the spinal center of bulge. So if peradventure we have a lesion along that pathway, then we're going to have a downstream effect and then a full-blown Horner syndrome through. The next is a tumor in the right lung apex. It's tumor in the right lung apex. That's actually true. That's affecting the second order neuron. Remember, we said that from the spinal center of bulge, we have the nerve going right into through the lung apex, and then under the subclavian goes to the neck before going into the angle of the mandible. So that's true. A large hematoma formation under the subclavian artery following attempted central line placement. Very true. Remember, we said that the that second order neuron nerve actually follows the subclavian before it gets into the neck. So A, B, C, and D are probable causes, while E is not a probable cause. So, our next question: which of the following is true regarding the sympathetic pathway to the orbit and face? A. The oculosympathetic fibers travel with the maxillary division of the trigeminal nerve V2 to the orbit. Now, that's false. We know that the oculosympathetic fibers actually travel with the ophthalmic division of the trigeminal nerve V1 to the orbit. So, B. The sympathetic fibers arise from the posterior hypothalamus. That is true. Let's hold that thought. C. The celospinal center of bulge is located at spinal level C6 to C8. That is false. It's located between the levels of C8 to T2 to T2. That's the celospinal center of bulge. D. The vasomotor and sweat fibers travel to the face along the ICA. That is false. The vasomotor and sweat fibers actually travel travels to the face along the ECA, the external carotid artery. Then E, the superior cervical ganglion is located near the level of the subclavian artery. That's false. It's located at the angle of the mandible. Okay, so the next question says that you are determined to further try to localize this lesion. Wow. Now, after placing 4% cocaine eye drops in the eyes, you notice that the left eye further dilates further, whereas the right eye remains unchanged. Which of the following can be definitely concluded based on this finding? Now, before we go further, let us try to understand the diagnostic tests for Horner syndrome. Apart from taking your clinical history, there are certain pharmacological agents that can be used to test whether a patient has Horner syndrome. Either you use cocaine eye drops or you use hydroxyaphetamine. Now, how does this work? For the cocaine eye drops, basically, cocaine prevents the reuptake of norepinephrine. So when you put cocaine eye drops in the eye, what happens is that you have failure to reuptake norepinephrine at the neuromuscular junction, and that means you have a lot of free norepinephrine. Now, if you have this free norepinephrine, it means that the dilator muscle of the eye, of the pupil, will then dilate if the sympathetic fibers are working. So, if in this case, if the left pupil reacts, that means it dilates when you put the cocaine eye drop, that means that left eye is fine. if the right eye does not react when you put that cocaine, that means that there is actually Horner syndrome. But this test does not tell us whether or not it is a first order, second order, or third order neuron lesion. It just tells us that, oh, there is actually Horner syndrome. Now, the next test that actually helps us to differentiate what order of neuron is affected can only help us to reliably say that it is a third order neuron versus it is not a third order neuron lesion. There is no pharmacological test that can tell you whether it is a first versus a second order neuron lesion, but we can only say, oh, this test is a third order neuron lesion or it is not a third order neuron lesion. That means either a first order or a second order neuron lesion. And what test is that? That's using the hydroxyamphetamine. Now, when you place hydroxyamphetamine in the eye, basically what happens is that it causes the release of norepinephrine from the third order neurons. And when norepinephrine is actually released, then this will then cause dilation of the pupil. Now, if that pupil dilates, it means that the problem is not from the third order neuron, it is from either the first or the second order neuron. If that pupil does not dilate, that means that the problem is from the third order neuron. So going back to our question, after placing 4% cocaine eye drops in his eyes, you notice that the left eye further dilates, whereas the right eye, which is the Horner's eye, remains unchanged. So that means that this is actually Horner syndrome. So which of the following can be definitely concluded on the basis of this finding? So A, the lesion lies between the second and third order sympathetic neurons of the right eye, that is false. B, there is sympathetic denervation to the right eye. Let's keep that. C, the lesion lies between the first and the second order sympathetic neuron of the right eye. That's wrong. D, the lesion lies between the first and second order sympathetic neuron and the third order sympathetic neuron of the right eye. That is false. And E, this finding is non-confirmatory of a Horner syndrome. That is false. This finding is actually confirmatory of a Horner syndrome, but it does not tell us which of the neurons or the which other neuron is actually affected. So we will say options B, there is sympathetic denervation to the right eye. Now let's go to number 10. You use 1% hydroxyamphetamine eye drops to help you localize the lesion further. After installation, both pupils actually dilate. Now, which of the following can be definitely concluded on the basis of this finding? So, if both dilate, that means that it is not a third order neuron problem. It's either a first or a second order neuron problem. So, A, the lesion involves the third order sympathetic neurons of the right eye. That is false. This finding disproves the presence of true Horner syndrome. That is false. The lesion lies between the second and third order sympathetic neurons of the right eye. That is false. The lesion lies between the first and the third order sympathetic neurons of the right eye. That is false. The lesion is proximal and does not involve the third order sympathetic neuron of the right eye. That is true. We'll go for options E.